Alright, so last time we looked at a lot of cervical pathology and mainly spent a lot of time looking at PCOS, right? Understanding all the medications for treating it and how to identify it and the whole pathophysiology of PCOS because clearly it's a pretty big deal. Now we're up to the ovarian issues, right? So ovarian things, ovarian cysts, ovarian neoplasms, and a bunch of different neoplasms are going to start showing up now. Keep in mind that we just said ovarian as well as when we get to the breast, all of those neoplasms are heavily related to age, right? So age is a big giveaway. Age as well as whether or not they're premenopausal, postmenopausal are two big giveaways for what condition someone might have. So the first thing we have here, ovarian cysts, right? We have a follicular cyst, and then we have the theca lutein cyst, which we got to hear a little bit about earlier when we were looking at the hydatidform moles and choriocarcinoma. So theca lutein cyst, you want to think of bilateral cysts, and it's usually due to gonadotropin stimulation associated with choriocarcinoma and hydatidform moles. So this part is pretty easy, right? Theca lutein cyst, not the craziest thing. If you have a question about a patient who just delivered and now they have these cannonball metastases to the lung, you think of choriocarcinoma, and then the question all of a sudden changes shift to something about cysts that are on both ovaries, theca lutein cysts. And it's easy to remember. The way I memorized that it was both is that I basically associated the two words as one name for each ovary. So one ovary is named theca, the other one is named lutein. That's something I just did in my head, and that's how I remember that it was bilateral. Two names for both cysts, both ovaries, one for each one. So that's your theca lutein cyst. A follicular cyst is a distension of an unruptured Graafian follicle. This thing, right? So when you're thinking of unruptured Graafian follicle, unruptured follicles we just saw were mainly related to PCOS. So a follicular cyst would be someone who has PCOS, right? And they tell you hyperestrogenism, which is clearly one of the things that were related to PCOS, as well as endometrial hyperplasia, which always occurs if you have hyperestrogenism. This is the most common ovarian mass in a young woman, except a follicular cyst is usually unilateral, right? It's not going to be bilateral most times. On the top row from UWorld, failure of ovulation is a common cause of infertility. Treatment options include the administration of drugs that act like FSH and LH. Menotropin, or human menopausal gonadotropin, therapy mimics FSH and triggers the formation of a dominant ovarian follicle. When the follicle appears mature, exogenous HCG is administered. The alpha subunit of HCG is structurally similar to LH and therefore stimulates the LH surge by inducing ovulation. Right? So just a little thing that you should know in terms of pharmacology for helping someone with infertility. That's one of the leading issues that you face in OB-GYN. A lot of times patients come in and they just have issues getting pregnant. Right? So you got to figure out what to do. In the last video, we talked about the progestin tolerance test and how giving progesterone and then withdrawing progesterone after 10 days of use would cause menstruation, because that's how progesterone generally functions, right? After ovulation, there's a rise in progesterone. It maintains the endometrium for some time, and then the progesterone starts to go low again, and then you have your period. So that's the progestin challenge test. Here we're looking at menotropin and the use of HCG to actually induce ovulation. Now we can move into ovarian neoplasms. So again, this part was easy, nothing bad, right? Follicular cyst, unilateral hyperestrogenism. Theca lutein cyst, both ovaries, and you can at the same time think of both lungs being involved because of choriocarcinoma, right? And hydatidform moles. Now ovarian neoplasm, most common at nexal mass in a woman over 55 years old, right? We saw this when we looked at the tumor epidemiology. Right here. So prognosis, cervical, endometrial, and ovarian. In ovarian, you can see here they put the prognosis gets really bad after age 65. You don't necessarily really see ovarian cancer in a younger female, and we said that one of the reasons people get ovarian cancer is because the ovary ruptures. Every time you release a follicle, your ovary literally has to explode open to let a follicle come out, and then you have to close that, right? So it's not like there's a door that opens and then the follicle just comes out. Where was I? Okay, so can be benign or malignant, arise from surface epithelium, germ cells, or sex cord stromal tissue, and that's what we're going to see here. Right, that's the first breakdown they have. Surface epithelium ones are benign, germ cell tumors also benign, and then the sex cord stromal ones, right, these are the benign versions of them. Right, and then on the next page you're going to start seeing the same stuff again. Surface epithelium ones that are malignant, germ cell tumor ones that are malignant, and sex cord stromal ones that are malignant. Now, of course, there's some overlap between the two groups, but mainly speaking, you don't, it's not like you have to memorize two sets of them. They're both pretty much named the same way too. It's just whether or not it's benign or malignant is how you're going to pick the answer choices. Majority of malignant tumors are epithelial, like serous cystadenocarcinoma, which is the most common. Risk increases with advanced age, infertility, endometriosis, PCOS, and if you have a genetic predisposition such as a BRCA mutation, Lynch syndrome, or strong family history. So we've seen all of these already, right? BRCA is different from HER2 because BRCA also involves ovarian stuff. Lynch syndrome, remember the rules of 3-2-1, like multiple generations, multiple cancers. That's all Lynch syndrome stuff. Risk decreases if the patient has previous pregnancy, history of breastfeeding, use of oral contraceptives is basically one of the treatments for PCOS, and tubal ligation. Presents with adnexal mass, abdominal distension, bowel obstruction, and pleural effusion. Monitor response to therapy or relapse by measuring CA-125. Right? And this is one of the things you monitor for ovarian cancer. Hey Brendan, thank you, and hi Mahesh. Yeah, man, 2020 I'm actually planning to do a lot of things to finally start advertising my channel. I've never advertised it before. I haven't done any paid advertisements like through Google or anything like that. And I recently started working with a bunch of what do you call them? Designers to get like a rebranding of my channel and start like publishing things on Instagram as well. Majority of my Instagram is going to be, I'm going to have two accounts on Instagram. One of them is going to be just a teaching one where I'll randomly have like really good questions and breakdowns and 1 minute simple videos by me to kind of talk about, you know, what topics are related to. And then another Instagram where it's just going to be more about me, because in 2020 I'm going to start talking much more about my own personal experience with things, whether it be medical school, my pre-med life, all my experiences and rotations. And then, of course, January, I'm also starting CK videos, so I'll advertise that on my Instagram as well. But yes, thank you. I appreciate it. Okay, so on the left, I just talked about BRCA and Lynch syndrome a little more, just as a revision thing, right? So Lynch was in GIT, and BRCA is listed with the tumor suppressors and oncogenes, right? BRCA is also going to be talked about more when we get to breast cancer. So let's take a look at all our benign things, right? So we have from the surface epithelium, there's serous cystadenoma and mucinous cystadenoma. Point being, they're both cystadenomas and they're both benign. The serous one is the most common ovarian neoplasm, lined with fallopian tube-like epithelium, often bilateral. Now remember, we're talking about the ovaries, right? And the epithelial lining was a pretty big deal. We talked about it earlier when we were in anatomy. Let's see. Right here, I remember that the squamocolumnar junction, just like we have one in our esophagus coming to the stomach, the squamocolumnar junction here is the transformation zone, right, where everything before is squamous, everything after is columnar, but your ovary is supposed to have simple cuboidal epithelium. Okay, now if you get a question where a patient is presenting with fallopian tube-like epithelium on an ovarian neoplasm, that's serous cystadenoma. Right, ciliated simple columnar epithelium. So that's what you're gonna start seeing, even though it's supposed to be cuboidal. So that's a pretty big giveaway. If they tell you something like that in a question, you should be able to just pick serous cystadenoma and move on. The mucinous cystadenoma has multiloculated large cyst with mucus secreting epithelium. So again, because it's mucus secreting epithelium now, you just pick the mucinous one. Right, but basically, cystadenoma is the one that is the benign epithelial tumor. This classification of the names is very important too, because you can have a question where the answer is serous cystadenoma, but your answer choice might be a benign surface epithelial tumor. You have to pick that. So If you can't remember, which one's surface epithelium, which one is germ cell, etc., it'll be a little harder. The way to really do it is to understand that serous and mucinous stuff is pretty much surface epithelial stuff. If you look at the other ones, like a teratoma, the mature cystic teratoma, that one you will know is a germ cell one because the tumor itself is going to have all 3 germ layers, right? So when we get there, we'll look at that. And then the sex cord one is going to have the sex cells, right? So we're going to see that later on as well. Like this one, fibroma, for example, right? We again see spindle-shaped stuff, right? Remember in the last video we mentioned that there are only a few things. If you could find the list, I have to find that list again, but there are only a few things that have spindle-shaped cells in them. And there was a guy on an NBME explanation that made that list, and I shared it in one of my NBME explanation videos. But spindle-shaped cells here, when you see this is not going to be a surface epithelium stuff, right? This fibroma is actually a sex cord stromal tumor. The easier one to remember is sertoli related, because these are both obviously gonad related, and then the thecoma, granulosa cells. Okay, so the fibroblast thing, I don't really try to think about the fibro part much. I try to remember the spindle-shaped and think of that as a sex cord cell. Right, the other thing that had spindle earlier from the last video right before this was right here. Right, spindle-shaped cells in the sarcoma botryoides, which is a rhabdomyosarcoma. And then, of course, other, right, the Brenner tumor. So that doesn't matter. But remembering this classification is pretty important. And cystadenomas are the surface epithelial benign tumors. So I'm going to go back and forth. I want to look at the benign versus malignant rather than doing it the way first aid has. So we just looked at the 2 surface epithelial benign tumors, right? One of them where in the serous cystadenoma we basically have fallopian tube epithelium, which means we have columnar epithelium instead of cuboidal. And the mucinous one where we have mucus secreting epithelium. So that was pretty easy. If we look at the malignant version of surface epithelial tumors, then this is serous adenocarcinoma and mucinous adenocarcinoma, right? This is just straight up pathology, naming of cancers, right? Pathoma kind of topic. So now that it's called a carcinoma, this is malignant, cystadenocarcinoma. The serous one is again the most common malignant ovarian neoplasm, whereas the previous one, the serous cystadenoma, was just the most common benign ovarian neoplasm. Again, this one is now frequently bilateral, and here is the S of psammoma. Right, so we have serous cystadencarcinoma. There's a mnemonic to remember all the things that have psammoma bodies, and this is one of them, serous cystadencarcinoma. You're going to have psammoma bodies, which is pretty much the giveaway for you to pick serous cystadencarcinoma. Both slides on the top right, these two over here, show serous cystadencarcinoma. The 2 red dots on the bottom left of the first image are psammoma bodies. If I make this bigger, this is an image from Amboss. So what you're seeing here, these are psammoma bodies. Right? They're definitely out of place, and you don't really see anything else in this picture that looks like this. So that's your psammoma body right here, serous cystadencarcinoma. Giving images like this to try to solve any kind of question, you have to keep in mind, like, you really need to see something that'll give away the answer. And if you can't really identify this as a psammoma body, you force it to be one, basically, right? Because it's not identifiable as anything else. This really can't be anything else. It must be a psammoma body. If you're talking about an ovarian neoplasm, just tell yourself it's a psammoma body and pick the answer, because I really don't see anything else in this picture that can give me a diagnostic answer. This one here, smear showing occasional psammoma bodies in between cell clusters. Again, right? This one is the image from USMLE RX videos from when I was studying. The other one, mucinous cystadenocarcinoma, is a rare malignant mucinous, again, ovarian epithelial tumor, may be metastatic from appendiceal or other GI tumors, can result in pseudomyxoma peritoni, which is an intraperitoneal accumulation of mucinous material, which might actually be in your question. So they might say there's a lot of mucinous material. They might try to confuse you into picking colon cancer as an answer choice. Don't fall for it. Why would you not fall for it? Because remember that ovarian neoplasms present in a very common thing, right? Adnexal mass, adnexal pain, etc., etc. Any adnexal stuff, when they mention it, just start thinking of the ovary. So that was a comparison between the surface epithelial benign versus malignant. They're named the same way, except one is adenoma, the other is adenocarcinoma. And the serous ones are bilateral, and it's basically the fallopian tube epithelium, and over here it was psammoma bodies. All right. The mucinous, same kind of thing again. They just have mucus, but this one is benign. The other one is malignant. Now we have our germ cell tumor. So the germ cell tumor that's benign is a mature cystic teratoma. Okay, and when we get to the male version of these things, the testicular cancers, there is some overlap there too, but do not confuse the two. Just because something presented in one way in a female does not mean that the male counterpart is going to be a similar presentation. It's very different for the male ones. So here, this is a germ cell tumor, the most common ovarian tumor in females that are 10 to 30 years old. Right? We just talked about it earlier that age is a huge demographic for figuring out the correct answer choice. Right? If you get a question about a patient and they just tell you a 20-year-old female came in and she has a tumor in her ovary, what could it be? And then you look at your answer choices, and if they have this there and they don't have some of the other answer choices that are very common, you go with this because this is the most common ovarian tumor in a young female. Cystic mass containing elements from all three germ layers. Can present with pain secondary to ovarian enlargement or torsion. A monodermal form with thyroid tissue uncommonly presents with hyperthyroidism. Malignant transformation is rare, and if it does occur, it's going to be squamous cell carcinoma. Now, we've seen thyroidization of stuff a lot of times so far, right? This is actually the second time that we're seeing thyroid tissue. No, the third time. Third time we're seeing thyroid tissue somewhere you're not supposed to have any thyroid tissue. All right, so this is an ovarian thyroid thing, right? Struma ovari. And don't let this throw you off. Okay, don't let this throw you off. But of course, test writers are going to love this topic because now you can have a patient presenting with symptoms of hyperthyroidism, right? And remember, if you have a 29-year-old female with symptoms of hyperthyroidism, but she doesn't have hyperthyroidism, you might even think she's having hot flashes because she's approaching menopause or something, you know. So don't start having those confusing thoughts because what I'm trying to say is that I can write a question where I present it in that manner, try to make you think, oh, this female is now menopausal, now she's having hot flashes, but she's really not having hot flashes. She's having hyperthyroidism, and it's not even due to her thyroid. It's because she has monodermal thyroid tissue in her teratoma, right? And we saw this kind of thing before too, right? There's a brain tumor that also occurs in the same area as your pituitary gland, where you can also have this kind of stuff, and you'll find teeth, hair, and sebum there too. So always be on the lookout for such comparisons. Now the malignant version of that, right? There's three different ones, right? Germ cell tumors that are malignant. There's three different ones. There's the dysgerminoma. It has germ in it, so you know it's a germ cell tumor. Immature teratoma, right? The mature one was benign. The immature one is malignant. And a yolk sac tumor, which obviously has a lot to do with germ cells. Okay, so dysgerminoma, this is the most common in adolescents, so we're thinking like young teenagers, equivalent to male seminoma, but rarer. 1% of all ovarian tumors, which means this is also practically going to be 1% of all your answers regarding ovarian cancer. 30% of germ cell tumors. Sheets of uniform fried egg cells, right? You're going to find ACG, and LDH is a tumor marker for dysgerminoma. Now, they show you the fried egg cells here, but again, this kind of image can really throw you off because you might not know what you're really looking for here, okay? But this is a dysgerminoma. Basically, what I think of this as is just a lot of big purple nuclei, really nothing else. You do need to compare all these images to each other, and it is very much possible for me to alter magnifications of these images to make them all look like each other. So these histological pictures alone don't necessarily do the job. So be very careful. Remember, you can't really get good at histology just looking at one picture. Histology requires you to look at many, many images of the same kind of thing so you can have a good understanding of the scope of what kind of histopictures you can get to show you a certain disease, and that takes a lot of time. So, you know, it might not even be worth wasting that much time on such a thing because most questions about this stuff should give you enough in the question stem itself for you to figure out the answer. If you're going to get something on dysgerminoma with a picture, right, then oftentimes test writers think of a picture as something substantial enough for them to take stuff out of the question stem. So if they give you something like image D, or even more zoomed in or more zoomed out, lower magnification, you really want to start canceling things out. Like, what do you not see, right? So you do not see any stromal bodies, you do not see any thyroid tissue, right? Stuff like that. And then you can go ahead and start looking at your answer choices and try to see if you remember anything that will really help. And there is stuff that will really help. This is actually just like fried egg cells, because if you look at the other guys, so an immature teratoma, this is very aggressive. It actually contains fetal tissue and neuroectodermal origin, right? Commonly diagnosed before age 20, just like the other one too, common in adolescents. Typically represented by immature embryonic-like neural tissue. And this is actually really cool because you could see that, but when we get a picture, they don't have a picture here for it, but if we ever get a tissue about immature teratomas, let me actually just try to find something real quick, because if you get a picture about immature teratomas, they'll give you that. Immature teratoma histology. Alright, so you're seeing fetal tissue, you're seeing all kinds of weird stuff, and let me see if there's anything in these pictures. Not really. Because this you can easily confuse for germ for fried egg cells too, if they give you an image like that. So you kind of see what I mean when I tell you you really have to know what you're working with, right? But look at this one. This is also, right? Yeah, this is also a teratoma right here, and they told you that it's got neuroectodermal cells in it, right? So you have to know something like that, because it's very evident that images of this alone with nothing labeled will not be enough for you to figure out immature teratoma. You just can't. It's not substantial enough. So be ready for that, right? Immature teratoma, they won't give you a picture, which means that if they did give you a picture and they didn't mention anything about neuroectodermal cells or fetal tissue or anything like that, the answer is probably not this one, so you can cancel it out, right? Then you're between other ones depending on malignant versus benign, and so on and so on. So I wrote here, mature teratoma had mature people things, teeth, hair, etc. An immature one has fetal parts, right? Which is, I guess, something I used to memorize it when I was studying before. So I don't even remember that now, but that's actually pretty good, right? So if you get a question where you have to pick between a mature versus immature teratoma, the mature one had actual things, teeth, hair, etc., whereas the immature one has fetal things, which are immature. That's pretty good. Yolk sac tumor. So this is also different from the dysgerminoma, because this is gonna have this thing, the Schiller-Duval bodies, which look very unique. So this is also known as ovarian endodermal sinus tumor, aggressive in ovaries or testes and sacrococcygeal area in young children. Yellow, friable, hemorrhagic solid mass. 50% have Schiller-Duval bodies, which resemble glomeruli, and you're gonna have elevation in AFP here, right? So it was LDH for dysgerminoma and AFP for a yolk sac tumor, which you can remember alpha fetoprotein with, the fetus anyway, right? That's kind of something you use to diagnose all kinds of stuff. So yolk sac is here. So I associate the yolk sac with AFP. And the Schiller-Duval body they're talking about is this thing, right? Very unique looking kind of cell. If they throw something like that in there, you immediately pick yolk sac tumor and you just move on in life. That's it. All right, so three different malignant germ cell tumors, and what's really important to remember with all three of them is that these are germ cell tumors, right? So germ cell means that they're like part of the endoderm, ectoderm, all that kind of stuff, very young. So these do occur in very young people, right? Very young. So age is a huge deal. Young children. Malignant germ cell tumor, young children. And this one was also, again, germ cell in young people. Nothing. So if your patient is over 40, it's most likely not a germ cell tumor. Then you have your sex cord stromal tumors. The benign ones are the fibroma, Sertoli Leydig cell tumor, and a thecoma. Fibroma is a bundles of spindle-shaped fibroblasts. There's something called Make syndrome, which is a triad of ovarian fibroma, ascites, and pleural effusion. Right? There's going to be a pulling sensation in the groin. And I think I have a practice question on this somewhere eventually too, because I have a bunch of practice questions to help you kind of identify cancers later on. But this is actually pretty significant, because a fibroma question will present with this. There's a lot of fibrosis, and that's what's causing the pulling sensation. All And the ascites is actually not so much related to the liver. Right? Usually ascites is like a huge giveaway for something wrong inside the liver, but in this cancer here, fibroma, ascites is actually not entirely related just to the liver. Right? So that's one thing. Sertoli latex cell, small, gray to yellow, brown mass. Resembles testicular histology with tubules or cords lined by pink Sertoli cells. May produce androgens, leading to virilization, right? And of course, Sertoli cells and latex cells. These guys, remember, we're talking about ovarian neoplasms, right? But Sertoli and latex cells were things we saw in males, right? Testes were the ones doing it. Females is supposed to be the theca interna and granulosa cells, not Sertoli latex. Right, Sertoli, so latex cells was the one releasing testosterone. Sertoli cell was the one releasing Müllerian inhibiting factor. All of a sudden, we have a tumor with those guys in a female, right? Because these are ovarian neoplasms. So, of course, virilization is occurring. And then thecoma, like granulosa cell tumors, may produce estrogen. Usually presents as abnormal uterine bleeding in a postmenopausal woman, which tells you about age, right? We're thinking of someone over age 40, 45. Over age 40, 45. So these three are also very different from each other. And in fact, all of these are very different from each other, which is great because there's no confusion, between picking one over the other. And then, thankfully, the benign versus malignant aspect is pretty similar. They're not that different from each other. So at that point, you can classify them together too. Like everything that was benign germ cell versus malignant germ cell, they were pretty similar in the sense that they all occurred in young people. So these were the sex core stromal tumors that are benign. And over here I wrote one more thing. Sertoli latex cell ovarian tumors present as an adnexal mass with amenorrhea and virilization due to increased testosterone. Patients are usually young women. Histology is similar to Sertoli cell testicular neoplasms for obvious reasons. Now let's take a look at the malignant sex core stromal tumor. There's only one here, and it's the granulosa cell tumor, which they said here is similar to thecoma, right? Like granulosa cell tumor. So what is the granulosa cell tumor? This one is actually pretty high yield. Most common malignant stromal tumor, predominantly women in their 50s, so usually near postmenopausal stuff, often produces estrogen or progesterone and presents with postmenopausal bleeding, endometrial hyperplasia, sexual precocity, so in preadolescence, and breast tenderness. Histology shows Call-Exner bodies, which are granulosa cells arranged haphazardly around collections of eosinophilic fluid, resembling primordial follicles. And that's what they're showing you right here. Right, this is a Call-Exner body. So give Grani a call is one way to remember that, and I have a couple more notes. So made of granulosa and theca cells, the granulosa part has small cuboidal cells and rosettes with coffee bean nuclei. The theca cells are plump with lipid contents that give the mass a yellow color on gross inspection, typically unilateral with estrogen-induced endometrial hyperplasia and a risk of carcinoma. Granulosa cells make estrogen and inhibin B, so both of those things will be elevated. All right. It's a very important one to watch out for. This one's actually pretty high yield. Amboss had another image that pretty much looks the same, right? So very important to just make sure you know. Right? This histology was pretty significant. So again, we can definitely identify these three from each other, but to get better at it, you need to look at more histology images. So you would just type like just dysgerminoma histology on Google, and you'll see more pictures, and you can practice that. But you got to be able to identify it from the image because the image is a big asset to getting it correct. And then later on, we'll do some of these questions I have down here. But the last thing we need to look at are the other, right? So there's the Brenner tumor and the Krukenberg tumor. The Brenner is benign, so I can definitely remember this B actually stands for a lot of things in Brenner. The word Brenner doesn't tell you shit, right? It doesn't mean anything. So when you see Brenner tumor as an answer choice, just think of the letter B and remember everything that starts with B, which includes benign, right? And then resembles bladder epithelium, solid tumor that is pale yellow, tan, and appears encapsulated, coffee bean nuclei on H&E stain. Okay, and now they didn't necessarily give any pictures for this in the book, but I added some. Right, so down here I have some notes. Let's take a look. High magnification micrograph of Brenner tumor showing the coffee bean nuclei on H&E stain. And then the image up here is from USMLE showing you a gross image of it. right? So you can see the pale yellow tan appearance, and it is encapsulated. Right, and this one here again, you can see stuff and coffee bean nuclei. That's really it. So let's take a look at this question down here. A 34-year-old woman with PCOS, the topic we just ended the last video with, comes to the office with her husband for treatment of infertility. She has been unable to conceive despite having unprotected sexual intercourse several times a week for the past 2 years. Her menses are irregular and occur every 2 to 3 months, consistent with chronic anovulation. She does not use tobacco, alcohol, or drugs. She takes no medications and has no allergies. BMI is 32. Physical exam shows coarse hair on her chin and abdomen. She is initially prescribed clomiphene therapy, but fails to conceive. She then receives ovulation induction therapy with a short course of menotropins, followed by a single injection of HCG. The use of HCG primarily mimics what physiologic event? And that's a very easy question to get right. You just pick LA surge, right? Because we just read that earlier up here. Right, so I think this was part of the explanation of that question, right? Menotropin is human menopausal gonadotropin, which mimics FSH and triggers the formation of dominant ovarian follicle. Then you give HCG, which has an alpha subunit that's structurally similar to LH. So it's mimicking the LH surge, right? Menotropin therapy mimics FSH and triggers the formation of dominant follicle. Exogenous HCG mimics LH because of the alpha subunit. Very easy question, right? And this is a very high yield topic. Your question can even be the other way around, where they actually tell you they did these things, and then they ask you, what is the point of giving clomiphene, for example. Clomiphene, we talked about in the last video also, is a high yield medication. Very high yield medication. It actually stops the negative feedback of estrogen on your hypothalamus. So that way your hypothalamus releases more FSH. And in PCOS, the issue is low FSH. They have high LH and low FSH. The last thing to look at was the other malignant version. So it's Krukenberg tumor, right? Brenner was the benign version of others, and Krukenberg we've already talked about, right? We've seen Krukenberg when we were in GIT. This is actually a GI malignancy that metastasizes to the ovaries, leading to mucin-secreting signet cell adenocarcinoma. Commonly presents as bilateral ovarian masses. Now, this is a very important thing to watch out for because, look, we have mucin secreting and it's bilateral. You cannot confuse that with mucinous adenocarcinoma, which is unilateral. This one is not really known for being bilateral, right? Even the benign version, mucinous adenocarcinoma, not really known for being bilateral. Okay, so all three of these things are probably going to be answer choices anytime you get a Krukenberg tumor question. And, if they mentioned a GI malignancy, that can, I guess, kind of help you pick Krukenberg tumor. But if they didn't, if they just told you there's a lot of mucin, then all three of those are viable answer choices. So the fact that this is bilateral is the giveaway that this is a GI malignancy just going everywhere, which is why it's bilateral. Okay. So that's basically it for now. In the next video, we'll talk about primary dysmenorrhea, and then we'll look at a bunch of practice questions before jumping to uterine conditions.